So we're going to kick it off with Dr. Ruby Lee. I'm so excited to have Ruby kick us off. Her topic is scientific updates on COVID-19, hazard and control. So Dr. Ruby Lee, our senior microbiologist and senior food safety specialist at NSF International. Ruby has served as in this position at NSF International since 2011. I've had the great fortune of knowing her all that time as well and working very closely with Ruby. Ruby completed a Master's of Science in Microbiology and a Ph.D. in Food Science and Technology, and was a postdoctoral scientist in animal science at Iowa State University. Dr. Lee is a much sought after speaker and an authority on various food safety and risk mitigation topics. She has supported numerous NSF clients with their COVID-19 programs, helping businesses to reopen and to stay open. So without further ado, Ruby, I pass it over to you.
Thank you, Paul, and good morning, everyone. Thanks for the opportunity to share a very important topic, scientific update on COVID-19 hazard and control. With only 15 minutes, I choose the hot topic, close contact, aerosol, silent spreader, fault mic contact, and more. Let's begin, shall we? In a cold day like that, let's warm up with a big questions. What is the best way to celebrate Thanksgiving safely? You can stay home, or if you choose to visit a local cultural center or museum. The first question is, what's the risk level of visiting a local cultural center museum during pandemic with exponential growth of new cases reported every day in US? Please log in your answer in your heart. I hear you. You are right. The correct answer is medium. For COVID-19 risk assessment, there are 4 primary factors to consider: enclosed space, crowds, duration of interaction, and whether we have activity of forceful exhalation. On the right middle corner, you see visiting a museum cultural center is categorized as medium risk based on being indoor and potential close contact. Museums have implemented many controls to reduce COVID-19 risk factor, including indoor and potential close contact, such as COVID-19 control check by NSF. On November 17, the second survey of 850 museums published in the National Snapshot of COVID-19 Impact on U.S. Museum showed that museums are operating at 35% capacity on average to reduce potential close contact. Do you know that the definition of close contact has been updated on October 21st by CDC? Now, the old definition was less than 6 feet contact for a continuous 15 minutes altogether in one shot. But then CDC updated the definition to less than 6 feet for 15-minute contact that could include short, multiple, cumulative contact within 24 hours, 2 days before illness onset by pre-symptomatic carriers, or 2 days prior to test specimen collection from asymptomatic carrier until the time the patient is being isolated. All this update definition is based on lesson learned from super spreading outbreak. The most recent one comes from the 20-year-old Vermont correctional officer who wore a mask and goggle. However, he had multiple short, brief encounters with 6 pre-symptomatic carriers who are transfer prisoners in cell, doorway, or recreational room without masks for a total of 17 minutes during the 8-hour shift. CDC highlights the importance that everyone must wear masks in public. Universal masking protects everyone in public. Please don't choose masks with exhalation valve or vent because it may release unfiltered respiratory droplet. Please choose masks preferably with 3 layers as source control to protect others by blocking respiratory droplet. You're welcome to watch NSF International webinar that was first broadcast in June, entitled Reopening Your Business and the Use of Face Masks. During that 1-hour webinar, you will learn the DIY mask material for optimal filtration to block the respiratory droplet that potentially with the viron, and also breathability that prevent you from suffocation. The second hot topic I want to talk about is aerosol. We all know that before July, the transmission mode cover mainly larger respiratory droplet bigger than 5 micron within 6 feet close contact and direct contact with COVID-19 carrier and indirect contact, 4 mic contact of contaminated surface that has been contaminated with respiratory droplet.
I'm always busy with tons of other stuff.
The third mode is aerosol less than 5 micron in medical aerosol generating procedures such as intubation. However, before July, the big question is, could COVID-19 be transmitted by aerosol suspended in the air more than 6 feet in a non-medical environment? July 9, WHO published the scientific briefing. Those are from lesson learned from some outbreak report related to non-medical environments such as quiet practice, restaurant, nightclub, fitness class, etc. In that scientific briefing, we clearly know that indoor, crowded, inadequately ventilated space over a prolonged period of time with infected person increase the risk of COVID-19 exposure. At the conclusion, short-range aerosol transmission cannot be ruled out. October, CDC published scientific brief, and they clearly state that, yes, the most transmission mode of COVID-19 is through larger respiratory droplet of more than 5 micron within 6 feet of close contact. Yes, direct contact should be avoided. Yes, indirect 4 mic contact should be avoided. Aerosol less than 5 micron in medical aerosol generation procedure, can generate aerosol. The big question is, can aerosol be generated in non-medical environment and promote COVID-19 transmission? The conclusion is there's no efficient rapid spread of aerosol with the viron, long distance and time. However, aerosol can be generated under special circumstances. What are some of the important factors that increase aerosol exposure risk? Number 1, incubation time. Symptoms onset of COVID-19 patients with the highest viral shedding. Number 2, if you are short distance with them. Number 3, if you expose yourself long time with them. Number 4, if you are in an environment with high density of people. Number 5, if there's little ventilation dilution, such as you're indoor with poor ventilation environment. Last but not least, if you are involved in activity that generate aerosol, for example, cough, sing, shout, and talk. Do you know that aerosol generated from normal talking can consist of up to 3,000 1 micron particle per minute? And there could be 250 viron per particle. A simple math gives us 750,000 viron per minute. Currently, we don't know the infectious dose of SARS-CoV-2 causing COVID-19. However, we're asking the question, could it be similar to SARS that we first seen in 2003, where the infectious dose is only 300 viron in certain situation? How do we control aerosol? We may be able to learn from the Guangzhou restaurant outbreak in China. it showed that aerosol transmission of SARS-CoV-2 due to poor ventilation may explain the community spread of COVID-19. How poor? The poor ventilation rate in the restaurant showed that it's around 1 liter of air per second per person. According to NC standard 62.1, ventilation of acceptable indoor air quality, the minimum outdoor air in a restaurant should be more than 5.1 liter per second per person. So in a Guangzhou outbreak situation, we realized the indoor air is at least 5 times less than the minimal requirement. What about museum? Museum's minimum outdoor air requirement is more than 4.6 for adult, 5.3 for children. Those are liter per second per person. And those numbers are pretty similar to a restaurant situation. Now, after talking about ventilation dilution, there's a very important publication come out that compare risk reduction and the cost using filtration and ventilation. And this study is called the HVAC, Filtration for Controlling Infectious Airborne Disease Transmission in Indoor Environment. The conclusion of this study showed that for reduction of infectious airborne disease in indoor environment, it appears that HVAC filtration of using a Merck 13 to 16 filter appears to be more cost effective than only relying on outdoor air ventilation. So in conclusion, to control aerosol, the basic requirement is to have minimum outdoor air per S-rate 62.1 guidance. Museum is recommended to have more than 4.6 to 5.3 liter of outdoor air per second per person. Now, you can also have filtration using Merck 13 filter or equivalent for recirculate air. So we dilute the air, also we filter the air. If you have higher budget, you can consider supplemental control. For example, air cleaner with standalone HEPA filter that you've seen in dental office, or UVC light, or other effective safe technology, or increased outdoor air. Where should we use it in the museum situation or cultural center situation? For example, if you have 4D theater with activity that promotes forceful exhalation, that people are so excited, they shout, they sing, they scream, that may promote aerosol, that may penetrate the face mask if they are not 3 layers or proper filter. So those are the situations you consider. The third hot topic I would like to talk about is silent spreader. On September 10, CDC published the current best estimate about viral transmission of COVID-19 from silent spreader. Who are they? They are asymptomatic carrier that never experience any symptom, and presymptomatic carrier that do experience symptoms later on. In the US, now transmission from asymptomatic carrier are about 40%. During presymptomatic, they are 50%. Viral shedding from asymptomatic versus symptomatic are about 75%. So we cannot underestimate all these silent spreader contribute to COVID-19 transmission. How do we control all these silent spreader? We need to identify and isolate them as soon as possible by rapid testing. Currently, we do have a lot of rapid tests involved in home swabbing, but then we have to mail it out for lab testing. On November 17, FDA authorized the first COVID-19 test for self-testing at home for prescription use. It is the Lucira COVID-19 all-in-one test kit. The beauty of this test kit is rapid, simple, accurate, and affordable. How rapid? Within 30 minutes, you get the result at home. How simple? It's a simple 4-step. You swab your nose with a proper method. You stir the nasal swab into a chemical vial, and then you put the vial into the test cartridge and start the automate lab reaction, And then at 30 minutes, you read the result, positive or negative, directly on the outside of the test cartridge. This test is accurate. 94% agreement, 100% agreement if we exclude the sample with very low level of virus that possibly not active infection. 98% negative agreement. Best of all, it is affordable of around or less than $50 US. It can be used at home, prescribed by your healthcare provider because you are a suspect COVID-19 patient. It can be used at point of care use at the doctor's office, hospital, ER. Prescribing healthcare provider, after receiving your result, need to report all test results to the public health authority for monitoring and tracking. The fourth hot topic I would like to talk about is the fault-might contact. People may say, well, Ruby, now we know the most probable transmission mode of COVID-19 is through respiratory droplet, direct contact. Is it a big deal to control fault-might contact? Yes. April 2020, Hong Kong scientists published an article to show that this virus can survive on surface from hours to days. For common material in a museum cultural center, such as wood, it can survive 2 days. What about stainless steel or plastic? Up to 7 days. Now, knowing that this infectious virus decreased over time. Also, this study was conducted for 30-minute contact, so it may not reflect casual contact of a surface. But we learned from this study, the virus can survive on certain surface for up to 7 days. October 7th, there's another study conducted by Australian scientists. The conclusion of this study showed that viable virus was isolated for more than 28 days at room temperature and 50% relative humidity in the dark for non-porous surface, such as the common surface we can find in a museum, like glass, stainless steel. Now, this more than 28 days appears to be significantly longer time period than the 7 days we see in the Hong Kong study. The good news is the virus only survived for 1 day at 40 degrees Celsius in the dark. How do we control fault-might contact? Well, we need to continue to follow WHO, CDC, EPA guidance for cleaning and disinfecting surfaces that potentially may be contaminated by respiratory droplet of presymptomatic, asymptomatic, or symptomatic carriers. Now, this short presentation, we just covered scientific update on fourth topic, close contact, aerosol, silent spreader, fault-might contact. What more do you want to talk about, Ruby? I want to talk about long-term effect. November 13, CDC update long-term effects of COVID-19 after recovery. It is a long list. Most common long-term effects such as fatigue after people recover. What about the common long-term effects such as brain fog that people cannot concentrate in thinking? I have friends in Iowa that suffer from that. It is very heartbreaking. If you look at the less common list, this is horrible. It is systemic long-term damage. These viruses do not only damage our lung function, but our heart, our kidney, our skin, our brain, also our emotion. Ruby, so far, it is so depressing of what you talk about. Can you talk about something make me happy? I try. In November, there are some good news. As you hear from the news, FDA emergency use authorization of drugs, Eli Lilly, and also Regeneron. You hear about President Trump used the one of the therapy being the Regeneron that recovers so quickly. These two drugs are monoclonal antibody mixed synthetically that can bind to spike protein of the virus to prevent the virus attachment and prevent human cell entry, to treat mild to moderate outpatients at high risk for progressing to severe COVID-19. Also, November 19, Eli Lilly granted the EUA for certain drugs to be treated hospitalized patients that need oxygen. Another good news that we hear from the news is about Pfizer and BioNTech vaccine that achieved 95% efficacy, Moderna 94.5% efficiency, and also recently we hear another company, the AstraZeneca, who achieved 90% efficacy. They're all seeking FDA emergency use authorization for all these investigational unapproved drugs. What are they? Now, for the first two, Pfizer and Moderna, they are messenger RNA vaccine. Once the messenger RNA being injected as vaccine to a human body, it will serve as a template to make the spike protein, which is harmless, to stimulate human body to build immunity. For FDA, the threshold to approve vaccine is 50% efficacy. Imagine we have about 70% people vaccinated. We may still not achieve the herd immunity to break the chain of transmission. With such a high efficacy of these two drugs at 95% efficacy, if we assume we have 70% of the whole population willing to vaccinate, we have big hope that the basic reproduction number will drop below 1.0 to achieve the herd immunity sometime next year. Even though we have the drugs, even though we have the vaccine next year, we cannot forget about the basic multiple hurdles, from monitoring health all the way to clean and disinfect. Together, we can help to break the chain of transmission of COVID-19. And may you all enjoy a safe Thanksgiving week. I can be contacted at the following email if you need any support. Thank you very much.